So Stuart Hooper from Melbourne, Australia, and his colleagues have done several studies looking at what happens when you ventilate the baby before or after you cut the cord. And using preterm lambs, they did it randomized. They compared the effects of ventilation before and after. They found that delayed cord clamping allows time for the infant to aerate its lungs and increase pulmonary blood flow before the venous return from the placental circulation is lost. And it avoided large swings in cardiovascular function, which I'm going to show you next here. So what you see, actually I'm going to go right to the next slide. I just want you to look at the pulmonary blood flow here. And you can see that the lambs on the left are the ones that were unventilated and had their cords clamped first. So they're recording pulmonary blood flow, and you can see it's not, when the cord is clamped, that the pulmonary blood flow actually reduces. I'll try to point here, you can see. Here, the baby has already been ventilated, and you can see a large pulmonary blood flow. And then when the cord is clamped at this point, I can't do that one so well, the pulmonary blood flow does not decrease. Pardon me?
Try your mouth.
Oh, okay. Very good. Thank you. You can see here that the pulmonary, whoops. Don't click your mouse. Don't click your mouse. You can.
Teenager.
I know, I don't have one. We're all grown up. So you can see here that the pulmonary blood flow is pretty stable and doesn't decrease when the baby is ventilated before his cord is clamped. This shows you, looking at heart rate, what happens when you clamp the cord. Now, the black circles represent the lambs that had their cords clamped first at time 1 and then were ventilated at time 2. And you can see in these lambs represented by the black circles that they had a huge drop in their heart rate right after the cord was cut. Heart likes blood. Time 1, the lambs who were ventilated first are represented by the open circles, and you can see there that those lambs have very little change in their heart rate when the cord is clamped. So it offers them some stability. Same is true here. This is the right ventricular output, but most, you can see here when you cut the cord right away and the babies that haven't been ventilated, their right ventricular output falls by over 50%. If that happened to me right now, I would be on the floor and not be able to continue my presentation. It wouldn't feel good. So the literature review also supports the safety of placental transfusion. There are quite a few studies now, 15 randomized controlled trials, 3 meta-analyses, and all of these studies show an absence of harm with a delay. In a very excellent meta-analysis that was published in JAMA, Hutton looked at 1,900 newborns, 1,000 with delayed cord clamping of at least 2 minutes, and 900 with early cord clamping. She found an increase in hematocrit, and she also found an increase in asymptomatic polycythemia. None of those babies needed treatment. At 2 to 6 months, significantly increased iron status represented by ferritin, stored iron, and less anemia, and no harm from jaundice or symptomatic polycythemia in any of these infants. I want to talk a little bit about cord milking because that's what I'm going to recommend that we could do when we have an extremely depressed baby. So I want you to be aware of this literature. There's no systematic review. There's 4 recent randomized controlled trials, 2 term, 2 preterm. There's 8 earlier controlled trials which are very well done. The Colosi trial is published in New England Lancet, and it's an excellent trial even if it was from 1954. They found the same early benefits as delayed cord clamping and absence of harm with milking, as we also found. What's important about the iron is that iron deficiency is due to low iron stores, and it has an effect even when the hemoglobin is normal. Shafir found that children had poorer infant motor development at 1 year of age. And Betsy Lozoff's work from the University of Michigan showed that even 20 years after successful treatment of anemia in infancy, these children at 20 years who had had iron deficiency anemia scored lower in cognitive, motor, social, emotional, and neurophysical development. There was an average drop in IQ of 25 points at age 19 if there was the double burden of iron deficiency anemia and low socioeconomic status. The way we think this works is that iron is essential for the maturation of these oligodendrocytes that make the myelin, which protects all the nerves and the transmission of pulses in our brain. They form sheaths around the axons and create the brain's white matter. And the decreased availability of iron is associated with hypomyelination in the brain. Okay, so placental transfusion is good, but what should we do and what can we do for infants needing resuscitation? And I say support a placental transfusion. And how do we do that? I want to go through our hypothesis for this talk, which is that placental transfusion prevents hypovolemia by increasing blood volume. That reduces inflammation, and that blood volume is critical to adequately perfuse and protect the newborn heart and brain. I got interested in this. I was teaching at midwifery at Georgetown, and I was also working part-time in a home birth service at the time in 1979. I had a baby at home that had a tight double nuchal cord, and it was born very limp with extreme pallor. It was the color of the sheet that I put the baby down on. I unwound the nuchal cord, lowered the infant. The cord was limp initially, and I, of course, left it intact at home. You'd be crazy not to. I dried and stimulated the baby and checked the heart rate, which was above 100, and I noted at that time that the cord was pulsing furiously. I could see the color returning in the baby. In about 2 minutes, the color returned. I was just getting ready to breathe for the baby when all of a sudden he opened his eyes, took a ever so quiet breath, and raised up his arms, got his tone back. He was breathing so quietly and shallowly that I had to take out my stethoscope to make sure that he was really breathing, but he was. So his APGAR at 1 minute was 2, his APGAR at 5 minutes was 10. I didn't cut the cord for a very long time. I last saw the baby when he was 1 year old, and he was doing fine. But I knew at that moment that I had seen something or experienced something fairly miraculous. I knew if I'd been in the hospital, I would have been forced to cut the baby's cord, and I wouldn't have seen what I saw. And I determined right then that I was going to study this, and so that this event has directed the entire second half of my life. So when I got into and there was very little literature available at that time, when I got into the nuchal cord literature review, our own Dr. Kishore did an excellent study showing hypovolemia in these babies. There's plenty of other studies showing hypotension, shock. These are case studies, of course. Birth weight reduction in a large study from Canada. The babies that had nuchal cord weighed less, as babies who have immediate cord clamping do. More hypoxic ischemic encephalopathy, CP, developmental delay, and death. So it's not to be taken lightly. Now these are all studies from Lind and O and Yeo and Nelle, and I'm not going to go over each of them, but I want you to look at euvolemia versus hypovolemia and what we can expect in babies. And you can see that if the baby is euvolemic, has had his placental transfusion, gotten his 30% of his blood, that he's going to have higher blood pressure, he's going to have lower vascular resistance, increased red blood cell flow to the brain and to the gut, increased renal blood flow done by our own Dr. O, increased urine output and decreased sodium excretion, increased pulmonary vasodilatation, also done by Dr. O back in the 60s, and of course increased hematologic indices. I think to me, what stands out most is the increase in the urine output, because most all our babies needing resuscitation that end up in the NICU have low urine output. We see that pretty consistently.